Good morning, everyone. Thanks for this opportunity to present as part of your meeting this year. I apologize about not being there in person, but I am delighted to be able to join you remotely today. So the title of my talk is Value-Based Purchasing in Nursing Home Care, Payment and Delivery Reform. This issue of value-based purchasing has been an issue that I've been studying for almost 15 years now. And the key takeaway from my research, and I think the broader literature as well, is that in order to really move the needle in terms of improving nursing home performance, you have to both change how you pay for nursing home services and healthcare services more broadly, but you also have to change how you deliver services on the ground. And so that's going to be the primary takeaway of my talk today. We need to reform both how we pay and how we deliver nursing home services going forward. So as an overview of my talk today, I'd like to start with a little bit of background on the US and Canadian nursing home systems. These systems obviously differ in a number of important ways, but I think we share some common problems. And these common problems suggest that there's a lot of potential for learning across our two systems. I'd like to use the issue of avoidable nursing home hospitalizations, which have been a focus of my work over the last 5 to 10 years, and I know a major problem in our system, and I understand from Paula an important problem in your system. And so I'd like to use avoidable nursing home hospitalizations as an issue to sort of stimulate our thinking about how we might begin to solve this problem at the delivery level, how we might begin to reform our system at the payment or policy level, and if we're going to combine these two ideas and actually change how we deliver services and how we, change how we pay for services, could we actually think about true system level reform? And then I want to conclude my talk with thinking about some of the challenges moving forward with this new system level reform. So let me start with an international perspective. This is just rankings of countries by the percentage of their gross domestic product that they spend on long-term care. This is from the 2008 OECD data. And those countries at the top spend the most on long-term care. Those countries at the bottom spend the least as a percentage of their gross domestic product. And the part of the figure in blue there, the bars for each of the countries, are their public long-term care expenditures. The part in red are their private long-term care expenditures. And then that green triangle out to the right is the projected public long-term care expenditures in the year 2050. So a few observations about this figure. First, it's always strange to see a ranking of healthcare expenditures where the US isn't on top. And so if you look for the United States, we're about 2/3 of the way down. Canada's a little bit ahead of us. So Canada spends about 1.5% of its GDP on long-term care, where the U.S. spent about 1% of their gross domestic product on long-term care. The next observation is both countries are shaded both blue and red, meaning both countries have some public funding for long-term care and some private. The Canadian system is more weighted towards the public. The U.S. system is slightly more weighted towards the private. And you'll note that the countries that spend the most, like Sweden and the Netherlands, are all in blue. They have public universal systems for long-term care. The US and Canada do not have public universal systems. They have mixed systems. And that actually suggests, once again, that there's this potential for learning across our two countries. So, two takeaways from this figure. First, this idea that we have a mix of public and private nursing home funding. We don't have universal systems. And then second, even though Canada does have universal funding for healthcare, you don't have sort of a universal system that encompasses long-term care. Here in the US, we have quite a bit of fragmentation in how we pay and deliver long-term care vis-a-vis other healthcare services. I understand from Paula that you have some of that same disconnect in Canada across healthcare and long-term care services. So that suggests two key policy problems from this common framework. The first problem is rising public nursing home expenditures. I'll present US data, but I'm certain I can construct similar trends in public nursing home spending in Ontario and Canada more broadly. So the trend line in green here are post-acute nursing home services. The U.S. system separates short stay and long stay nursing home expenditures. So the green trend line are those rehab or short stay post-acute spending on nursing home services. The blue trend line are those long-term care residents in nursing homes. And then the red line just combines both the Medicaid and Medicare expenditures. And the takeaway here, is the U.S. went from about $115 billion in spending in the year 2004, and then we project out to spending $250 billion by the year 2019. So a huge increase in spending over a relatively short period of time. A real issue of concern for policymakers, of course. I think as an economist, rising expenditures don't bother me per se. What bothers me is whether we're getting value for this increase in spending. And that's really been the point of a lot of my work and others investigating whether the U.S. Nursing home sector provides quality commensurate with the level of investment from different public sources. And you can see here that there's been a number of reports and studies and media articles suggesting low quality. I've put up a study from the General Accounting Office, an Institute of Medicine report, and a front page New York Times story. There's obviously a long list of academic studies and papers documenting low quality care in the U.S. Nursing home system. I, of course, could generate a similar literature review and find similar studies on the Canadian nursing home sector as well. So this is the first problem. We're spending a lot and we're not necessarily getting a lot back always in the way of quality of care. The second problem is that our investment in nursing home services doesn't just lead to lower nursing home quality. Our investment in nursing home services may actually spill over to the use and quality of services elsewhere in the healthcare system. And these are some data that were put together by some colleagues at Brown that just show the trend in hospitalizations of long-stay nursing home residents in the U.S. You can see that from the year 2000 to the year 2008, we saw an increase from 19% of all long-stay nursing home residents being hospitalized in a calendar year up to 21%. And so, to summarize, 1 in 5 long-stay nursing home residents, those who stay in a nursing home for greater than 90 days, are hospitalized in the U.S. system. And many of these residents are hospitalized multiple times within a calendar year. This is a real problem. And in talking to Paula, I know this is a problem in the Canadian system as well, there in Ontario. So the key question is why? And I'd like to use this issue of avoidable hospitalizations to motivate the rest of the talk and how we might fix the system here in the U.S. and potentially there in Canada as well. Why do we have so many avoidable hospitalizations? Well, I want to dig down into this issue further in just a few minutes, but I first want to start with a patient vignette. Now, I'm going to use a patient in a U.S. nursing home as an example, but I believe this patient could be in an Ontario nursing home as well. So consider Miss B. I'm not a clinician, I'm a health economist, so I don't have patients, but I borrowed one from one of my co-authors, Joe Oslander. And he and his colleague, Bob Berenson, published an EGIM perspective and used the case study of Miss B to motivate their piece. And so I'm going to borrow Miss B for the purposes of our talk today. She's 90 years old, she lives in a U.S. nursing home, and she's dually eligible for Medicare because of her age and Medicaid because she's exhausted her income and assets and now meets the thresholds to qualify for the Medicaid program. In terms of her health, she has moderately advanced Alzheimer's. She has congestive heart failure with severe left ventricular dysfunction. She has chronic pain from degenerative joint disease. Now, under the traditional payment and delivery model here in the US, Miss B would have 3 ID cards. She would have her Medicare card for her healthcare services, her prescription drug card for her drug benefit, and her Medicaid card for her long-term care services. 3 different sets of benefits that aren't very well coordinated with one another. And she'd have a series of providers that she interacted with: the nursing home in which she lived in, physicians, therapists, our hospital, who rarely communicate or work with one another. So when a change of status arises, the kinds of decisions that need to be made about Miss B's care are not made from a team-based, coordinated perspective, but rather they're made in a very uncoordinated fashion, with financial interests and not Miss B's interest at heart. So imagine what happens when a health issue does arise. Imagine Miss B develops a non-productive cough and a fever of 100.4 degrees Fahrenheit. This is eminently treatable in the nursing home setting, my clinical colleagues assure me. But in the typical scenario here in the US, she's going down the street to the hospital. I want you to think for a second about this type of resident. All of you that work in nursing homes have patients like Miss B. Issues like this come up. They come up in the evenings, weekends, at all hours. What happens in your nursing home? She develops this cough and this fever. Are you able to care for her there on site, or do you send her down the street to the hospital? If you send her down to the street to the hospital, why? I think I have the answer in the US system, and I believe that the answer in our system is going to be very similar for your system as well.